Imagine inventing a medical diagnosis,
Right.
right? A label that ends up being given to millions of people worldwide over, I mean, decades.
Mm-hmm.
And then years later, you just casually admit that you only created it for, quote, a group of patients that didn't have a diagnosis, but which drove everybody crazy.
I mean, it sounds almost like a cynical joke, but that is a real documented quote.
That's wild.
Yeah, that is from a 2016 interview with John Gunderson. And he is the psychiatrist widely considered the founding father of the borderline personality disorder diagnosis.
That is just a staggering confession. And, it perfectly sets the stage for our mission in this deep dive today.
Yeah.
We are looking at a really incredibly compelling article.
Well, absolutely.
It's from the March 2026 issue of Psychology Today by clinical psychology professor Dr. Bobak. It's titled, Reviving the Original Meaning of Borderline. And the goal today isn't just to talk about, general mental health.
Right.
We're going to explore how one of the most famous, heavily stigmatized diagnostic labels in the world might actually be based on a massive scientific misunderstanding.
Yeah, and crucially, we're going to look at how tearing that rigid label down is actively reshaping the future of how we treat profound psychological distress.
Okay, let's unpack this, because to understand why this label is currently crumbling, we kind of need to understand how it was built in the first place.
Definitely.
So before the 1980s, before BPD became this standalone, highly specific diagnosis that you could just look up in a manual, what did the word borderline actually mean in a clinical setting?
Well, historically, it was never meant to be a noun.
Oh, really?
Yeah, it wasn't a distinct disease you could, have. In early clinical theory, it was used purely as a metaphor, almost like a geographical term. It indicated severity.
Okay, severity.
Clinicians used it to describe a state of mind or a level of functioning that sat right on the border between neurosis and psychosis.
Gotcha. I just want to make sure I'm mapping this out right for everyone. So neurosis would be what? Like distressing but generally grounded emotional struggle?
Exactly.
Like severe anxiety or depression, but you still know what's real and what isn't.
That's a solid way to frame it. With neurosis, your reality testing is intact. Psychosis, on the other end of the spectrum, is where a person is actively losing touch with reality.
Right.
Like experiencing severe hallucinations or delusions you might see in schizophrenia. So to call someone borderline meant you were observing a marked, severe character struggle.
Like they were literally on the borderline.
Right. It was a way of communicating to another doctor, hey, this patient is experiencing a profound level of impairment and their functioning is deteriorating right on the edge of these two states.
So it's a sliding scale. You're basically evaluating how much pressure the line can take before reality starts to fracture.
Yes.
But then the 1980s roll around, and the psychiatric community publishes the DSM-III, the Diagnostic and Statistical Manual of Mental Disorders.
The famous DSM-III. Yeah, this was a pivotal moment. The field of psychiatry was under immense pressure at the time to prove itself as a hard, rigorous medical science.
Right. They wanted to be taken seriously.
Exactly. The creators of the manual wanted to make mental health diagnosis as precise as classifying different species of plants, basically. So they took this abstract, metaphorical concept of being on the borderline of severity, and they forced it into a box.
Meaning they transformed an adjective into a noun.
They abruptly made it a distinct standalone category, a syndrome. And to do this, they actually had to separate it out from other conditions it used to overlap with, like schizotypal personality disorder.
Wait, let's pause there. What is schizotypal personality disorder, and why do they have to separate it?
So schizotypal personality disorder involves pervasive patterns of intense social discomfort, eccentric behaviors, and cognitive distortions.
Like what kind of distortions?
Like magical thinking or extreme paranoia. It's much closer to the cognitive fracturing of schizophrenia. But borderline patients were presenting more with severe emotional volatility and relational chaos.
Okay, I see.
So the task force looked at this messy reality and essentially just drew an arbitrary line down the middle. They said, okay, the cognitive distortions go into this box called schizotypal, and the emotional volatility goes into this new box called borderline personality disorder.
But didn't anyone raise a hand and say, hey, maybe human minds don't work like sorting laundry?
Right. You would think.
If you're drawing arbitrary lines, surely the experts at the time saw the flaw in that.
Oh, they absolutely did. The skepticism was rampant from the very people writing the manual.
Really?
Yeah. Alan Francis, who was a Q advisor on the DSM-III task force, he explicitly warned that the concept had been so loosely applied it had lost all precise meaning.
Ah.
He pointed out the obvious. If you rip borderline away from the context of bordering on schizophrenia or psychosis, what is it supposedly bordering on anymore?
Right. If there's no border, the word is completely meaningless.
Exactly. And Theodore Millon, another pivotal task force member, was even more blunt. He argued it was perhaps the most poorly chosen term in the entire manual. He insisted that borderline signifies a level of severity, not a descriptive type of personality.
Well, I'm trying to think of a parallel here. Tell me if this works. It feels like looking at a patient who is sweating, shivering, and has an elevated temperature. That is a fever.
Right.
A fever is an indicator of severity, right?
Yeah.
Tells you the body is fighting an underlying infection. But what the DSM-III did would be like a group of doctors deciding that fever is its own highly specific standalone disease rather than a sign of broader distress.
That captures the core mechanical flaw perfectly. You take a systemic distress signal and brand it as the root cause.
But this brings up a massive contradiction.
Okay.
If the very creators and advisors of the DSM-III, like brilliant people like Francis and Millon, knew this was a terribly chosen label that made no clinical sense, why did they cement it into the diagnostic Bible? Why didn't they stop it?
It ultimately came down to bureaucratic inertia.
Really? Just paperwork?
Basically, yeah. Francis noted that the term was perpetuated simply because there was a lack of wide agreement for any substitute term.
That is wild.
They had this massive pool of difficult-to-treat patients. They needed to categorize them for insurance and administrative purposes, and they couldn't agree on a better name, so they just shrugged and stuck with the flawed label.
They locked generations of patients into a diagnostic framework that they knew was fundamentally cracked from day one just because of administrative convenience.
It's tragic, honestly.
So the manual is published. The label is out there. Suddenly you have millions of people being told they have this highly specific entity called BPD. When actual scientists and researchers started testing this new category in the real world, what happened?
Well, the scientific unraveling began almost immediately. Dr. Bach's article walks us through decades of empirical agony on this.
Empirical agony, I like that.
Just a few years after the diagnosis was introduced, a major 1988 study by researcher Fire and his colleagues rigorously analyzed the data. And they concluded that BPD was essentially an overly inclusive catch-all syndrome.
I have to push back a little here. How do you actually prove a diagnosis is a catch-all? Was it just that a lot of people were getting the label, or was there a structural problem with the math?
It was a structural problem with the math.
Okay, break that down for me.
So, the manual lists 9 potential symptoms for BPD. Things like fear of abandonment, impulsivity, intense anger, feelings of emptiness. To get the diagnosis, you only need to meet 5 of the 9.
Any 5.
Any 5. If you run the math on that, there are 256 different combinations of symptoms that can result in a BPD diagnosis.
256.
Yep. You could have 2 patients sitting in a waiting room, both diagnosed with borderline personality disorder, and they might only share a single symptom in common.
Wow, so they are experiencing almost entirely different struggles,
Yeah.
but they are shoved into the exact same box.
And it gets worse.
Oh, great.
Fire's team also found massive diagnostic co-occurrence, meaning people diagnosed with BPD almost always met the criteria for other completely different personality disorders at the same time.
Like they have multiple labels.
Right. The overlap was so extreme that Fire's team questioned if BPD could even be said to exist alone.
If the boundaries were that blurry, how were clinicians in the 80s and 90s actually distinguishing BPD from just, I don't know, severe trauma or a really chaotic phase of life? Was it just entirely subjective based on the doctor?
In many cases, yes, which is why some international bodies were highly suspicious of it. The World Health Organization's manual, the ICD-10, only provisionally included it as a subtype of something they called emotionally unstable personality disorder.
So even the WHO wasn't buying it?
Not fully. And this skepticism was validated by a major Norwegian study in 2004 by Johansen. Johansen looked at those individual criteria we just mentioned, the impulsivity, the anger.
Right, the 9 items on the checklist.
He found that those individual criteria were actually more closely statistically associated with other personality disorder categories than they were with BPD itself.
Let me wrap my head around that.
Mm-hmm.
The actual symptoms of the disorder don't mathematically cluster together.
Exactly.
So like the symptom of impulsivity might correlate closer to antisocial personality traits, while the fear of abandonment might correlate closer to dependent personality traits. They don't form a cohesive standalone illness.
They don't. From 2015 all the way up to a comprehensive study by Mueller in 2026, empirical data-driven research consistently shatters the notion of BPD as a distinct, isolated disorder.
Okay, I have a major problem with this timeline, though.
Shoot.
If the data has been screaming this doesn't work since that fire study in 1988, why on earth has BPD remained the go-to diagnosis for 40 years? Why did it take half a century for the psychiatric establishment to change course?
This is where we run into the sometimes cynical reality of medical research. You have to look at the incentives. Having a massive, overly broad catch-all label like BPD was incredibly useful for researchers and pharmaceutical companies.
Because it made it easy to find subjects.
Precisely. If you are trying to get funding for a clinical trial or you're trying to publish a paper on a new group therapy protocol, you need a neat, recognizable category to put on your grant application.
Oh, wow. BPD provided a huge pool of easily accessible patients. It functioned as an administrative dream. But the tragic irony is that while this diagnostic ambiguity made it easy to run studies, it made it incredibly difficult to actually help the individual human beings sitting in the therapist's office.
Because you were treating the label, not the person. Going back to our fever analogy, you have a whole hospital ward of people with fever disease.
Yes.
One has a bacterial infection, one has a virus, one has heat stroke. Because they all share the label, you give them all the exact same antibiotic, and then you are baffled when it only cures a fraction of them.
That is the exact trap the field fell into. But if the symptoms don't cluster together, it raises the vital question, what are these patients actually experiencing? Because their pain is very real.
Right. We can tear down the diagnostic manual all we want, but there are millions of people out there suffering from profound emotional chaos. If it's not a syndrome of 9 specific symptoms, what does the modern data show is actually going on? This is where we see a profound shift toward empathy in the science. In 2017, researcher Peter Fonagy and his team found that the features we typically call BPD actually map much better onto a global index of mental distress.
Okay.
And specifically, they tied it to 2 things: a severe lack of resilience, and a breakdown of fundamental trust.
A breakdown of fundamental trust.
Mm-hmm.
That is a very academic phrase.
Mm-hmm.
What does a breakdown of fundamental trust actually look like in a person's day-to-day life?
Think about it as epistemic trust, the basic ability to rely on the social knowledge and intentions of others. Let's say a friend texts you and cancels dinner because they're overwhelmed with work.
Sure, happens all the time.
If your fundamental trust is intact, you might be disappointed, but you accept their reason. You trust that their boundary is not a personal attack on you.
You bounce back.
But if you have experienced a breakdown in fundamental trust, your mind cannot process that benign explanation. Your reality testing falters.
Oh, I see.
You instantly perceive the cancellation as a malicious abandonment. You believe the world is inherently hostile, that everyone is eventually going to betray you. And the intense, chaotic reactions we associate with BPD, the frantic texts, the sudden anger, the severe depression,
Right.
they're actually desperate attempts to manage a world that feels fundamentally unsafe and unpredictable.
That makes so much sense. It takes the blame away from the individual having a quote-unquote broken personality and reframes it as someone whose core psychological immune system, their ability to trust the world, has been compromised.
Exactly.
It's a completely different lens. So how is the psychology field taking this realization and finally fixing the diagnostic system?
Ironically, they are fixing the future by going back to the past. They are returning to the clinical wisdom of the 1960s, specifically the work of psychoanalyst Otto Kernberg in 1967.
Oh, Dr. Bach mentions him in the article. What was Kernberg's approach?
Kernberg completely rejected the idea of borderline as a discrete syndrome. He introduced the concept of borderline personality organization.
Organization. That implies we are looking at the architecture of the mind under pressure, not just a list of bad behaviors.
Exactly. He viewed it as a structural level of functioning on that dimensional spectrum we talked about earlier between neurosis and psychosis. Instead of looking at symptoms, Kernberg looked at the underlying mechanics of the mind. He focused on things like identity diffusion and impaired reality testing.
Okay, identity diffusion.
Yeah.
I'm struggling to see how a clinician actually measures that in a room with a patient. How do you test for a diffused identity?
It actually comes out really clearly in clinical interviews. A clinician might ask a patient to describe themselves or to describe a significant other.
Okay.
A person with an integrated identity can describe nuance. They can say, my mother is very loving and supportive, but she can also be incredibly stubborn and dismissive when she's stressed.
Yeah.
They can hold positive and negative traits in the same cohesive picture.
And someone with identity diffusion.
They often can't integrate those traits. Their descriptions become flat, chaotic, or entirely contradictory.
Like swinging back and forth.
Yes. They might say, my mother is a literal saint who saves everyone, but then 10 minutes later say, she is a monster who ruins everything she touches. They lack a cohesive sense of who they are and who others are across time.
Wow.
They split the world into all good or all bad because integrating the two is just too psychologically taxing.
So the focus moves from what is your symptom to how is your mental software processing reality right now? How does that 1960s theory translate to the cutting-edge models being rolled out today in the 2020s?
We're seeing it in the newest versions of the diagnostic manuals, the ICD-11 globally, and the DSM-5, the Alternative Model of Personality Disorders, or AMPD.
What are they doing differently?
These new models are finally doing what should have been done 40 years ago. They are ditching the rigid categories. They are abandoning the standalone BPD diagnosis.
They are actually deleting the box. What takes its place?
Dimensional assessment. They now capture those familiar borderline features by focusing on global personality functioning.
Global personality function.
Yeah, clinicians evaluate a person across 4 core domains.
Okay.
Their self-perception, their self-direction, their empathy, and their intimacy. It's about plotting where you are on a continuum of functioning.
Guys.
The more pronounced the impairment is across these general aspects of human life, the more it resembles what we used to erroneously call BPD.
If we connect this to the bigger picture, this shift feels revolutionary.
It really is.
So, what does this all mean? It sounds like the mental health field is finally upgrading from a blunt, binary pass-fail grading system, where you either have a disorder or you don't, to a highly detailed, personalized progress report. You are looking at the whole person, identifying exactly where they need support rather than just stamping a stigmatized brand on their forehead.
That is the ultimate goal. It shifts the clinical question entirely. We are no longer asking, what category of disorder are you? We are asking, how is your personality functioning right now? Where is your trust broken? And how severe is your distress?
But wait, I have to throw a massive caveat into this.
Okay, let's hear it.
BPD has been the dominant paradigm for decades. You mentioned earlier that the label was an administrative dream for research. That means there are thousands of clinical trials, billions of dollars of research, and massive Cochrane reviews based entirely on this broken BPD label.
Yes, the Cochrane reviews are crucial here. For those unfamiliar, a Cochrane review is essentially the gold standard of medical research. They pull together dozens or hundreds of clinical trials to definitively determine if a treatment actually works.
Right. And there are Cochrane reviews proving that certain therapies work for BPD.
Yeah.
We can't just erase that history overnight because we changed the manual. Do we just throw all that data in the trash?
We absolutely do not throw it out. There is a treasure trove of vital, life-saving information in those decades of research. What the field must do now, as Dr. Brock emphasizes, is act as translators.
Translators, walk me through how that works.
We have to look at the established literature on individuals with a BPD diagnosis and view it through this new dimensional lens. We treat the old BPD features and the data as a proxy for global personality dysfunction.
Oh, I get it.
So when an old 2010 study says dialectical behavior therapy is highly effective for borderline personality disorder, we mentally cross out the old label.
Right.
We translate it to mean this therapy is highly effective for individuals experiencing severe impairment in global personality functioning and acute emotional distress.
We keep the clinical wisdom, but we discard the stigmatizing framing. To everyone listening right now, whether you're dealing with a medical system or just navigating your own relationships, this isn't just academic jargon about how doctors code insurance billing.
No, not at all.
This is a profound philosophical shift in how we understand human pain. It emphasizes that mental health isn't a world divided into healthy, normal people over here and broken, disordered people in isolated boxes over there.
It acknowledges that mental health is a universal spectrum of functioning, of resilience, and of fundamental trust. Every single one of us is on that spectrum. Sometimes we function well, and sometimes the distress becomes severe. By reviving the original meaning of borderline as a measure of severity rather than a toxic personality trait, we are bringing empathy back to the forefront of diagnosis.
I want to leave you, the listener, with a final thought to mull over today. We've just explored how one of the most famous concrete medical diagnoses in the world turned out to simply be a severe point on the universal spectrum of human distress. It really makes you wonder, What other rigid labels, whether in the doctor's office, in the generational divides we argue about, or just in how we silently categorize ourselves, are we treating as absolute biological truth? What other neat little boxes are we squeezing ourselves into that might actually be blinding us to our shared, incredibly messy human experience?
Because when we finally dismantle the boxes, we actually start to see the person.
I couldn't agree more. Thanks for joining us on this deep dive. We'll catch you next time.